Okay, the quadriceps muscle group.
Here.
Sartorius muscle.
From the ASIS down through here.
The patella.
Here.
The quadriceps tendon.
Here.
The patellar tendon.
Here.
The tibial tuberosity.
Here.
The lateral meniscus and joint line.
Here.
The fibular head.
Here.
The lateral collateral ligament.
From there to the condyle.
The popliteus tendon.
That's just posterior to the LCL.
The biceps femoris tendon.
Here.
The IT band.
From Gertie's tubercle to the lateral portion here.
Gertie's tubercle.
Just lateral to the tibial tuberosity.
The medial meniscus and joint line.
Here.
The medial femoral condyle.
Here.
The medial tibial plateau.
Just inferior to the joint line here.
And the medial tibial flare.
Distal to that, right down here.
The medial collateral ligament.
From the flare to the condyle here.
The pes anserine tendon.
Here.
Pes anserine bursa.
That is between the skin and the tendon.
Semitendinosus tendon.
Here, medially.
The gracilis muscle.
From the pes anserine up the medial inside of the thigh.
The hamstring muscle group.
Here on the back side.
The popliteal fossa.
That's this diamond-shaped fossa between the tendons.
The head of the gastrocnemius muscle.
Coming up in here. Okay, now I'm going to go on to active range of motion. I would palpate all of those, of course, bilaterally, and as well as active range of motion. So can you slide your heel to your butt and then bring it out again? And I would compare that, and then going on to goniometer. The fulcrum, like on the joint line here. Okay, can you extend? That's about -3, which is normal. And then I'm gonna bring you up an extension. All the way, yep. That is about 138, which is normal, 135 to 145. So now I will do passive range of motion, bringing foot all the way to your butt, and that flexion would be a soft end feel, and then on extension, it's a firm end feel, comparing bilaterally. And then next I'll do manual muscle testing, so I'll have you extend your knee off of the end of the table. And then push up, 5 out of 5, and then I'll have you flip onto your stomach for flexion.
Oh gosh.
Bring your foot up to your butt again. Good, 5 out of 5, and now point your toes inward. And now come up, 5 out of 5, and then outward. Bring your leg up again, 5 out of 5 on that as well. And then I compare bilaterally. And now I will go on to special test. The patient for all the special tests would be supine, but sitting up because she's videotaping me. So I'm going to, for the sweep test, I'm just gonna sweep this together. And if there was swelling here on the medial side, that would be edema and swelling of the joint capsule there. And then the ballotable patella, I'm just gonna push down on the patella here. And if it was a floating patella or it was going downward, then that would be joint effusion. Next, I will do Noble's compression. So I will put my hand over the condyle, and I'm going to flex and extend, and I'm looking for popping and snapping over that, and that would be the IT band, and it would be IT band friction syndrome. Next, I'll do 90-90. So if there was a divot here in the tibial tuberosity, that would be a PCL sprain. Next, valgus in full extension, applying a valgus force. That's testing the MCL, the cruciate ligaments, and the medial joint capsule. And then varus. Oh, and then also, before I go to that, valgus in like 20 degrees flexion, and that will just test the MCL. And then varus in full extension, a varus force will test the LCL, the lateral joint capsule, and the cruciate ligaments. And then in like 20 degrees flexion, it will just test the LCL. Next is the lateral pivot shift. So I'm going to internally rotate the tibia while applying a valgus force and slowly flex up the leg. So keeping it internally rotated, valgus force, and that's going to test for anterolateral rotary instability. Next, I'm going to do the anterior drawer. So I'll have the patient flex their foot up, and I'm going to sit on their foot, and then my thumb's on the plateau. I'm going to be pulling it forward, and if there's increased laxity on the tibia was coming forward, that would be ACL sprain. And then next, I'll do the sulcum drawer, which is just like anterior drawer. First, I'll internally rotate and then pull forward. And that again will be testing the ACL and the LCL. It will be anterolateral testing there. And then external rotation, I'll sit on it, bring it forward. Again, it'll be ACL as well as anterior medial rotary instability, and that is the MCL. Next, I'll do Lockman's. So I'll rest their leg on mine, stabilizing the femur, and then bringing the tibia anteriorly, and that is going to be testing the ACL as well. Posterior drawer, flex up again, sitting on their foot. Now I'm going to be pushing posteriorly to check the PCL, and if there is excessive laxity, or like the the tibia is moving posteriorly excessively, then it's PCL sprain. And then Houston's posterior medial, I will internally rotate and then again pushing back. That's going to be checking the PCL as well as the MCL. And then posterior lateral, externally rotate, and then pushing back, PCL and MCL. So if the tibia was moving backwards on that, it would be positive. Next, I will have the patient stand up.
I don't know how you want to do this.
So I will have you on one foot. The affected leg will be weight bearing, and then about with 5 degrees flexion, so just a little bit, I will have them internally and externally rotate the femur. So kind of just twisting, and if there was pain or clunking, it'd be a meniscus tear, and then I'll have her do it again with increased flexion, and then just internally and externally rotating, and same thing, meniscus tear. McMurray's is the next one. So I'm going to internally rotate the tibia, holding over the joint capsule and bringing them up and extended, and then externally rotating again down here. And then whatever side I feel popping or pain, if the person has pain and there's popping, it would be meniscus again. And then Apley's, can you lay on your stomach? And I'm going to stabilize and internally and externally rotate while applying pressure downward, and then externally and internally and externally rotate while pulling upward. So the compression and distraction of that, and if there's pain with the compression but it's relieved with the pulling, the distraction, then that's also meniscus tearing. Next I'm going to do myotomes and dermatomes. So for that, L1 is going to be through here towards the top area of the groin. So I'd ask the patient to close their eyes and ask sharp, dull. And then L2 is just moving down a little for the dermatome. So sharp, dull again, patient's eyes are closed. They tell me the difference, what they think. And then moving down more to like the middle thigh area. Sharp, dull. That was L3. Now L4 is over the patella. And then going even lower for L5 is lateral lower leg. And then for S1, it is the lateral hamstring. So, and then for S2, medial hamstring. For the myotomes on that, L1 is hip flexion. So I'll have them bring their leg straight leg up, flexing their hip, and that is the same for L2. So it'd be that same motion. L3 is knee extension. So come off the end of the table and just extend your knee out. Yep. Ankle dorsiflexion is for L3. That last one was L2, this is L3. So bring your toes up towards you. And then L5 is great toe extension. So just your big toe would be brought up towards you. And then S1 is ankle plantar flexion. So step down the gas pedal. And then S2 is knee flexion. So bring it back towards you. And now I'm going to do the reflex testing. And for L1, there is no reflex, but for L2, it is the patella. And this is for L2, L3, L4, and L5. So it moved there good. And then on the bottom down here is S1 and S2 on the Achilles. And there's not a lot of movement, but it's there. And that concludes my testing. And for all those, it would be tested bilaterally as well.